So I start with Dr. Mishra, sir. So, sir, you oversee management of hyperglycemia of around 100 to 150 patients daily. So, in your experience, what all and who all are required for an optimal inpatient hyperglycemia management?
So I think it's a team effort, right? So you and individually it is very difficult. Whenever we have worked individually, we have tried to help good glycemic control. It is very difficult. So we have seen step by step change in management of in hospital hyperglycemia. We have more number of the doctor in team. We have the resident doctor, and the care really improved after the we have the DNB doctors who are pursuing the endocrinology course in our team. So because they are well learned people and they know about and they are interested and they are 24 into 7 available in the hospital. Afterward, the next step was the diabetes educator. So diabetes educator really fills the next gap in for the in hospital glycemia management. So many a time you patients are going discharged without any particular advice. They are not aware about the insulin injection. For 5 7 days we have done a good glycemic control, but of course when they reach home and they are not aware about the usage of the insulin. So it's not only a consultant, but the team of the doctor that required for the in-hospital hyperglycemia management that I discussed in the presentation. It's not very difficult. I will tell you, it's not very difficult. We have a large volume hospital, so we need more people. But just identify your hospital when you have a set of patients. So if you have a 50 bedded hospital, of course, then 20 patient will be having diabetes, and you have to have a good diabetes educator. So we can help you in getting your diabetes educator trained for the diabetes management. We run a course in our department. So diabetes educator course is for 6 months, where they get hand-on experience about the diabetes management in hospital as well as the outpatient setting. And then of course it's a learning is a continuous process. So every day we become wiser whenever we see more and more patients. So this is how we are here in discussing the in hospital update for hyperglycemia management. Thank you.
Thank you. So the next question is to Dr. Khalid, sir. Sir, you cautioned the accuracy of POC meters in inpatient hyperglycemia monitoring. So according to you, should there be a protocol that at certain point of time the POC meters should be calibrated with venous blood?
So I think in all hospitals, the biomedical engineering calibrates these glucometers regularly. Huh. So these meters are being calibrated regularly by the biomedical team. Okay, and especially if you get abnormal readings, you should question. Don't take all these values at face value. Okay, so we have seen during COVID with vitamin C what kind of hyperglycemia was found, and a patient was absolutely normal, and a glucose meter would give a reading of 540. Patient was just sitting comfortably, and we sent a sample, a blood gas sample. It came out to be 78 or 80 in that range. So whenever in such a scenario, if it is not kind of meeting the clinical endpoints, or like if you find that this it needs to be questioned, I think a venous sample should be drawn. We should not act hastily just on the basis of a single glucose value.
So the next query, uh, as we have seen that intravenous insulin infusion is the standard of care for critical ill patients, but if in any facility there is no, the intravenous insulin infusion is not feasible, so can intermittent subcutaneous insulin be used in critical care settings?
So it will be very difficult to control the hyperglycemia, especially by the intermittent subcutaneous insulin dose, because it takes time. Then there is absorption, peak time, and the pharmacokinetics of the subcutaneous insulin is entirely different from the pharmacokinetics of the intravenous insulin. I think in after say 15 in last 15 20 years there is a sea of change. the insulin infusions are readily available in most of the hospitals. They do not cost too much, and it is very easy to use those insulin infusion pump rather than giving the subcutaneous. But of course, when you don't have anything in a very stressful situation like during the COVID, when you are not having anything, so giving insulin is right. You have to give the basal insulin, but only take away message from giving subcutaneous insulin is that basal insulin should be given. You should not consider to give sliding scale insulin, which of course will be discussed by Dr. Parjeet in subsequent discussion why the sliding scale to be avoided. So basal insulin has to be there, and then you monitor the glucose frequently. Then you can give intermittently the bolus insulin as per the glucose level, and try to maintain a steady state of the insulin level and the glucose level, and avoid hypoglycemia.
So I'll just make one comment. So my practice has changed when I was at Medanta, because there I could use the insulin infusion in the floor also. Now in my hospital, I am not allowed to use insulin infusion in the ward setting at all. So it's not, the administration does not allow the use of infusion on the floor. The person has to be in the HDO or ICU for any such infusion. So in that scenario, yes, the workaround is to use intermittent bolusing. Obviously, with the help of basal and bolus, I'm able to control it in a fairly okay manner. So it all depends on the institution, the administrative support, because it was like, if it is 500, you start infusion. So now if it is 500, I cannot start infusion. So I have to go by maybe short boluses over the next 2 to 3 hours to control that. So yes, we'll have to kind of adapt to situation.
You are giving IV bolus.
No IV, subcutaneous boluses. Subcutaneous, no IV.
So, Dr. Khalid, just one point I would like to make.
Yes.
You're telling that it's the the administration point of view, but with the discussion should be from the the evidence based, and what should be the correct way of giving the insulin,
So hospital
rather than
thinks
saying
that,
it's the
no, the thing, no, it's not about the cost. It's mainly about
No, evidence,
hypoglycemia.
I'm just saying evidence based. So if this sugar is like 500, should we give it insulin infusion rather than
So
saying
see, that 500 has to be accompanied by certain other clinical sets. Okay. So if 500 is with diabetic ketoacidosis, definitely that is a different scenario. But in a normal person who 500 who has say a pre-dinner of 500, not everybody would need to be shifted for infusion. So if he's is clinically okay, I would manage him with subcutaneous boluses also.
so it depends on from the clinical status. point
Yeah,
of
so
view.
I can get a venous blood gas at that time. I can get the stat plasma ketone at that point of time and decide about that. So I think obviously it will be on the basis of the other clinical factors. But because all these either insulin or IV infusions, so IV calcium gluconate or even potassium, it's not allowed on the floor.
So it depends upon where you are working.
Yeah.
True.
Even in NHS also, infusion, variable rate infusion, where they have certain things like glucose, like you have to kind of infuse glucose along with insulin so that there is less risk of hypoglycemia. The flow, it is not allowed on the floor. It has to be either in the HDO or ITU or the ICU.
But ideally, if you have opportunity, you would like to use insulin.
Yes, definitely it is
More convenient.
convenient, yeah. But then we have to see the practical aspects of it.
Right, sir. So the next question is to Dr. Khalid, sir. So according to you, what is the utility of CGM devices, especially in critical care settings?
So as such, see, the thing is that in patients where I want to minimize the number of pricks where the glucose values are fluctuating too much, in that scenario, definitely I would be using that. But then, as you had seen, there are so many other factors which are affecting the accuracy. In that scenario, it doesn't look, it gives us a very pleasant outlook. Okay, So maybe in the sometime later when we have more data to be used, definitely it will have a lot of kind of bearing on the ICU outcomes also. We have seen that it identifies hypoglycemia as well as lowers the hypoglycemic events, because you are able to see that will be possible when you are using a glucometer which alerts you towards that. So if it is signaling that, okay, if after 15 or 20 minutes the glucose can go to that extent, some corrective action can be taken. So it can guide us, especially in those who are on insulin infusion, type 1 diabetes, who are on pump. Definitely it will be very useful in that setting.
Right, sir. So this is definitely an area for future research.
Yes.
So next question is to Dr. Sunil Mishra, sir. Sir, you highlighted the important role of diabetes educator in patient hyperglycemia management. So how can we utilize admission of a patient for proper diabetes education?
So, any question from the floor is also welcome. So, please take the opportunity to ask the question. So, the diabetes educator really fill the gap in the inpatient diabetes care. So, when you have a diabetes educator who is well versed with the diet, insulin, hypoglycemia care, so it really off burden you from the large set of the in-hospital hyperglycemia care. So earlier days when we have to call patient to the floor for diabetes education, so there used to be a little bit of the pressure on the diabetes educator when they used to come to floor, and many a time because of the nursing pressure on the floor, patients were not visiting to our floor for the diabetes education. So now what we have we have changed the policy that all patients are seen then and there by diabetes educator in the floor itself. So before the discharge alert goes to the diabetes educator. So they take care of the diet part as well as the insulin part, monitoring hypoglycemia, and in the discharge advice we tell them when to follow. So this closes the gap which I was talking about the discharge, because this discharge advice is very important. As I discussed, OPD glycemic control is poor. So the type of the patient who is coming to the hospital will always come with the poor glycemic control. You have a window of opportunity in 5-7 days to show at least 140 to 180 glycemic control and allow patient to go in a good glycemic level. So I will give you one example of one of the patients. So this situation is very difficult. So one patient was planned for a neurosurgery. His glucose level was 300, and when we did the HbA1c, this is the highest HbA1c I have seen, is 21. And I discussed with the neurosurgeon that we need a good glycemic control, at least give me 2 week time so we can get the surgery. So he told me that patient is from Doda, Jammu and Kashmir, and he will go back in next 3 days. So I have to do the surgery. So yes, so this was a challenge. So I told them then we have only opportunity to start the insulin infusion. We control the glucose and discharge patient on multiple short insulin, followed the patient in remotely in OPD basis. Patient did well, and of course then a loss of follow-up after 6 months. So most important part of the in-hospital hyperglycemia is the perioperative glycemic control or peri-procedure glycemic control. Many a time people who come in the hospital, the outcome goes well with the, not only with the HbA1c, but more with the peri-procedure during in hospital and after discharge, how well you've been able to held the glucose level in control. And for that, you need a team, and the team, the soldier of the team are the diabetes educators.
Yes, sir. So the next query is to Dr. Khalid, sir. Sir, as we have seen that transitioning a patient who is on IV insulin to subcutaneous insulin, there are many errors. So according to your experience, what practical tips would you like to give to transition a patient from IV to subcutaneous insulin?
So whenever we are see, IV to subcutaneous will be happening in the ICU setting once the patient is planned for ward shift. Now, usually that happens after the morning round. So if you are there at that point of time, because say if you are taking rounds at 9 or 10, at that point of time, you can order for the long-acting insulin to be given at that. So it will depend on various other factors, what has been the previous glycemic controls, what is the overall oral intake at the present time, any other things, whether patient is on steroids. So as we had mentioned that that there is one thing that you take into account 24-hour picture or the last 6 hours or 4 hours. There are various patterns. Each one is kind of can be followed. So the best thing would be to give a basal insulin at the time of rounds itself, so that allows us to that even if the patient gets shifted, say in the afternoon or evening, you will have some control, because in the intervening period, part of the infusion will be missed. And so rather than again receiving a call that the glucose values have rose up to 400, with a basal, maybe it will not kind of climb to that. So I think at the time of rounds, usually what I do is that I give a basal shot at that point of time. I discontinue the insulin after an hour or so, and then write the bolus component at that point of time.
Thank you, sir.